Good afternoon, Senator Rafferty, Representative Brennan, and honorable members of the Education and Cultural Affairs Committee. I'm Justin Chenette, Sweetser's Senior Director of Public Relations and Advancement, and I'm here today to kick off our team's testimony in support of LD 2002, an act to provide incentives to schools that contract for certain social work and family therapy services. It is fantastic to be back before this committee as a former member of the Maine State Board of Education and back before many of you who I served with in the Senate and the House of Representatives for 8 years. Your public service and commitment to Maine's next generation does not go unnoticed. I'd also like to thank Speaker Talbot Ross for her leadership and interest in putting this idea forward. Our entire behavioral health community appreciates her passion for youth and for finding solutions to addressing the mental health challenges Mainers of all ages face. To continue to set the scene, Maine teen suicide rates exceed the national rates, with Maine students who seriously considered suicide increasing to 19%. 36% of Maine high school students reported feeling sad or hopeless, with nearly half of Maine teen girls feeling similar. 14,000 Mainers aged 12 to 17 have depression. 14,000. To help meet this growing need and demand for preventative mental health services, Sweetser is meeting the moment at a great financial loss. Sweetser provides treatment in over 25 school districts and in over 100 public schools, including elementary, middle, and high schools. Sweetser has approximately 80 school-based clinicians across the state of Maine, and we served over 2,300 students last year in schools from Kittery to Bangor, and I attached a full list for you in the packet. We are embedded on school campuses, working alongside the dedicated public education staff who are consistently being asked to do more with less. Mental health support takes a village, and providers like us are one important part of that puzzle. Every single year, this program loses money. Not many organizations would keep that afloat, but we do. It's where our heart is. It's not sustainable without you, though, without passing and funding this bill. I don't, and I'm sure you don't either, want to see on the 6 o'clock news or the front page of the paper 100 plus Maine public schools no longer providing youth mental health treatment. That's not a faint possibility. It's an absolute reality if we don't find a path forward together. In summary, this bill before you would allow the Department of Education to set up a grant-like incentive for schools to contract with a behavioral health provider to provide school-based therapy services. This would reduce costs for schools, help financially stabilize the program for providers like us, and ensure students get the mental health support they and their families really need. Behind me, we have a number of speakers that will break down the problem we're trying to solve, why this program is so impactful, and the difference between the different types of school-based supports for addressing mental health of Maine's next generation. Really appreciate you hearing this bill and this important topic, and I hope over the course of the hearing today, you'll see the value in preventing school-based therapy services from shutting down. That is what is at stake today and the decision before you with this bill. Thank you for your time and for your consideration.
Good afternoon, Senator Rafferty, Representative Brennan, and honorable members of the Education and Cultural Affairs Committee. My name is Jane Van Bramer, and I am the president and CEO of Sweetser. I'm here today to speak in favor of LD 2002, an act to provide incentives to schools that contract for therapy services. You know, research shows that half of all mental illnesses begin by age 15. Despite this glaring statistic, only about half of these children will receive treatment, and even less will receive evidence-based interventions. That is treatment that makes a difference. LD 2002 is designed to change that. Accessing behavioral health services in Maine and across the country is difficult. Sweetser alone maintains an extensive waiting list, yet we know that early identification and preventative interventions are the hallmark of an effective behavioral health care system. For parents of youth, Barriers to treatment include the need to take time off from work for appointments, travel distance challenges, and inadequate funding to support behavioral health interventions. Because children spend the majority of their day in educational settings, schools play a critical role in providing a safe, non-stigmatizing, and supportive natural environment in which children and families can have access to prevention, early intervention, and treatment. A study by the U.S. Department of Health and Human Services indicated that youth are more comfortable accessing services through school-based clinics. Schools provide a natural setting in which students can receive needed supports and services, and where families are comfortable and trusting in accessing these services. Studies have shown the value of developing comprehensive school mental health programs in helping students achieve academically and building social skills, self-awareness, and caring connections to adults, both in their school and in the community. Schools that partner with behavioral health entities have been proven to significantly reduce rates of truancy and discipline, increase high school graduation numbers, and help create a positive environment in which the students can learn and thrive in the school and in the community. The purpose of this bill is to improve access to mental health resources, support students who have experienced anxiety, depression, or trauma, and to support those adults that surround them. It is not to replace existing school support staff, not to replace guidance counselors or school psychologists or school social workers, but to establish, expand, and enhance services through a partnership with an experienced child-serving behavioral health organization. Where they exist, existing school staff can play a critical role in terms of being a liaison to that behavioral health organization and triaging students to services which the school itself is not really equipped to handle. Our school therapists work 12 months a year and have helped literally thousands of Maine youth navigate bullying, anxiety, depression, parental divorce, and other adverse childhood experiences. Cost is the biggest barrier as to why every school does not have an in-school therapist. In fact, Sweetser operates this program at a loss and supplements it with revenue from other programs and donations because we believe in its prevention mission so strongly. But it is simply not financially sustainable for any provider. This bill will stabilize the program and ensure its continuance. Maine is poised to have a surplus of several $100 million. The time to invest in our children's future is now. The time to act is now. Thank you, and I'm happy to be a resource for this important bill.
Good afternoon, Senator Rafferty, Representative Brennan, and other honorable members of the Education and Cultural Affairs Committee. My name is Wendy Anders. I live in the town of Biddeford, and I am a Sweetser employee. I am a senior director of our community-based services. I'm here with my other colleagues in support of LD 2002. School-based therapists partner with school-hired counselors and school social workers to form a continuum of care to support students' mental health needs. Each role has its own specific purpose, and when working together, the team provides a comprehensive support network for the child and the family. Schools that are fortunate enough to have each of these roles available in their buildings are able to use a 3-tiered system of intervention for students with mental health, behavioral, or learning needs. This tiered system demonstrates that there is a need for each type of role in the school environment. It's not duplicative. Tier 1 is typically the first tier of force, the first encounter, if you will, or it's usually the guidance or school counselor role. They're the folks who are available for all the students at the school. Tier 2 are typically school social workers, school hired social workers that are available for any student based upon an identified need. The final tier, or tier 3, are those school-based outpatient therapists that often could be available outside of the school in the community, but much more effective when they're available inside the school. Students with more acute needs are referred by the school to address more in-depth, complex, long-term issues. To break down the differences between the three roles a little bit further, a school hired counselor, sometimes referred to as a guidance counselor, is available to all the students. They might provide some classroom instruction on social skills and social issues, teach coping skills for mood regulation and behaviors. They also meet individually or in small groups with students to solve problems, addressing friendship issues or conflict resolution. And in high schools, the school counselor might also be available for academic and other support, career planning support. Many guidance counselors are not necessarily certified to be therapists, and many school social workers or school therapists are not certified to be counselors. School hired social workers that are hired for general population and the school milieu are often available for very specific reasons and are assigned either due to IEP issues or other behavioral issues that are presenting themselves at the school. These school hired roles do have some family contact, and this is usually by phone or in meetings that happen oftentimes at the school. The school hired personnel usually work the traditional 42-week calendar, and they have school vacations and summers off. The final tier, the school-based outpatient therapist, are services that are clinically served and provided within the school center to ensure accessibility to those who might not be able to access services in their community. Therapists work with individual students and their families in their schools, their homes, and within the community year-round. This means after-school hours, vacation weeks, and summers. When organizations like Sweetser contract to partner with schools, we take the school's lead. When the school personnel assess that a student and/or a family require more services than the school can offer, then the school personnel will obtain permission from the parent or guardian and then refer the student and family to an organization like Sweetser. If a school doesn't have a therapist co-located in their facility, then they might decide to refer outside of the school to either a community mental health center or a private therapist. However, because in this scenario, the provider isn't co-located in the school, the follow-through doesn't always happen, and the ability to provide that on-site teamwork is lost. This is why schools are actually seeking out partnerships with organizations like Sweetser. I hope this helps to illustrate the differences between the roles and the added value that it brings to have all involved at the schools. I'm happy to answer any questions.
Good afternoon, Senator Rafferty, Representative Brennan, and honorable members of the Education and Cultural Affairs Committee. I'm Joanne Grant from Gray, Maine. I heard that I needed to say where I was from, and I'm a rule follower. I have been in the behavioral health field for 28 years and at one point practiced as a school-based clinician myself. Currently, I'm the Chief Growth Officer here at Sweetser, and I oversee school-based programs as part of my role. I am here today to speak in favor of LD 2002. Sweetser places licensed professionals in schools at no cost to the school district. They bill the student's insurance, but the reimbursement rate only covers the actual face-to-face time that the clinician spends in session with the child. There is so much more to this position than simply back-to-back therapy sessions. It requires full integration within a school setting, which Wendy mentioned, and a number of key activities that we as the provider simply cannot bill for. This creates a gap that we cannot fill without your support and without passing this legislation. I want to tell you a little bit about the non-billable activities that we participate in. We meet families where they're at, not just in the school setting. The time the clinician spends commuting to and from to see clients and their families is not reimbursable, and some clinicians in rural areas travel up to an hour or more round trip. Unless the documentation is completed during the client's session, the time to edit and complete the documentation is also not considered reimbursable time. Conversations, meetings with teachers, primary care physicians, psychiatrists, case managers, other school personnel such as the school nurse, school social workers, and counselors, all important team members, as well as school administrators when a child is in crisis, are not considered reimbursable time. If a child is in crisis and a crisis worker is called to the school, the school-based clinician's time is considered not reimbursable because the crisis worker is present, but often the client or the family requests that that clinician stay because trust has been established. School personnel must obtain permission to refer before handing off the referral to a school-based clinician. And then the clinician needs to make calls to prospective clients and guardians to schedule the actual intake appointment. Calling the client and families that first time can be time consuming because I often have questions and concerns about what the service entails, and rightfully so. Then there's ongoing maintenance to manage schedules. Our clinicians are often chasing families for consents and plan approval paperwork, sometimes meeting in parking lots to get it. Reviewing client charts in preparation for a session, staying on top of all communication from clients, families, schools, the organization, and other stakeholders in order to be prepared for each session happens on a daily basis, and these are not reimbursable activities. School-based clinicians must maintain the proper number of continuing education units and supervision hours to meet licensing requirements and to be trained in the most current evidence-based practices. They are all considered non-billable time. There are a number of insurance barriers that result in unbilled time as well. Obtaining insurance authorizations can be very time-consuming. And if a session is interrupted or isn't long enough, which happens in a school, it cannot be billed for. Making referrals for other support services and following up on those referrals, including calling to find out eligibility requirements and how long wait lists are not reimbursable services or activities. We need to cover these critical activities. Thank you for your time and your consideration, and I'm happy to answer any questions.
So I'm the medical director for Sweetser. My name is Mark Kaplan, DO, and I don't look it, but I've been at Sweetser for close to 30 years. Okay, trained at Maine Medical Center. And I'm in support today of LD 22002, an act to provide incentives for schools that contract with certain social work and family therapy services. So in Maine, we have many people that live in very rural areas, and they have a hard time accessing mental health services in communities. Okay, so for many people over the years that I've worked at Sweetser who need a care of a psychiatrist for medication management and things, we've had families that drive an hour to an hour and a half for a session, and the sessions with psychiatry usually occur once a month per se. But then we want them to have therapy, okay? And it would be ludicrous for us to expect these families to drive an hour and a half there and back every week for therapy sessions, okay? I can't tell you how ineffectual that would be, because we're trying to help families in our therapy sessions to learn how to have, quality life as a family. And the quality of life is not spent driving 3 hours a week in a car. Okay. Many of these children that we care for, and I think Speaker of the House mentioned some statistics for you, and others that have spoken before me mentioned statistics. It's undeniable that children, we have 200,000 children in Maine schools right now. And such a large percentage of them are struggling with trauma issues, with depression, with substance use disorders, with attentional problems. And there's no doubt it's overwhelming the teachers, the school hired guidance counselors, the school hired social workers. So what we've learned is that, children with these problems, they're going to have behavioral problems in school. That's going to disrupt the education for the other children. They're going to have poor academic achievement. They're going to struggle to get to graduation. So we found that schools, we've been doing the school-based therapy work for, I think, close to 25 years, okay? Because we knew right out of the gate that this was a valuable service and a service that could meet children and families where they are at, okay? So schools are really the ideal place to diagnose and treat children with mental, emotional, and substance use disorders. It's natural settings. And I'm going to tell you, when they come to me, my first question is, well, how's this child doing in school? Because I'm trying to diagnose and evaluate them. And when I have a school-based clinician working in the school, a behavioral specialist working in the school, whether it's from Sweetser or if I'm working with a school district to have somebody from another agency, either way, I get real-time information. I get very illuminating information that I can't get otherwise. Because in this school, these behavioral specialists are well-trained. They're evidence-based trained, okay? And they have to be evidence-based trained because we expect it, we provide the training, and the state expects it of us as a mental health provider. So we're very family-focused in our work. What does that mean? That means we definitely get permission and consent to provide the treatment, but that's not all. We involve the families in the treatment. Now, it's a lot easier to involve a family if they live 10 minutes away from where the work is being done. It's much harder to get them to drive the hour to hour and a half away to the mental health center. So that's where the action is. That's what's going on. I also want to punctuate mental health parity. Okay, what you're starting to see across the state, which is really good, you're seeing dental clinics in schools. We're seeing Health Reach that I work with. They're providing some basic preventive medical care in schools now. Okay, the mental health care is essential. We work with an agency nationally called the National Council for Mental Well-Being. They absolutely believe and have published studies that show the school is where the action is to provide interventions. Everyone is justifiably worried about what we see, school shootings and things like that. And when you study the data on those children, you find out they had depression for years that went untreated. And so imagine that if our interventions are preventing some of those horrific tragedies. So in conclusion, we're on a cutting block right now. We've had testimony that shows that our school-based services are gasping right now and may have to close. And that would be tragic, absolutely tragic. So we want to, we're here, and I'm grateful, so grateful for your time. And just we're desperate with you to make sure that we can continue to provide these vital services. Thank you so much.
Senator Rafferty, Representative Brennan, and honorable members of the Education and Cultural Affairs Committee. My name is Hannah Schlotterbeck, and I am a Sweetser school-based clinician in 2 schools, in Brunswick, where I live, and in Harpswell, serving children starting in pre-K through the 5th grade. I'm speaking today in strong support of LD 2002, an act to provide incentives to schools that contract certain social work and family therapy services. I believe in this work, as I deeply believe in the potential in each individual child and their family system. The overwhelming majority of my kiddos qualify for main care, have a caregiver or caregivers who work long, hard hours to support their family, and who benefit greatly from having access to mental health services during school hours and in collaboration with their schools. It is a true team approach. In addition to my individual and family therapy sessions, many of which are informed by individual and generational trauma, I work closely with school social workers, school counselors, school behavior specialists, teachers, and principals to figure out how to best support each child, their family, and what they need from me, their family, and from their school environment. I began working with a dear child in the 2nd grade in the fall of 2002. He was artistic, athletic, very angry, bright, confused, and expressed a low self-image with frequent negative thoughts about himself. He received behavior slips regularly at school, resulting in generally staying inside from recess and sitting in a separate room for lunch due to some targeting of his peers and inappropriate comments and behaviors. And most concerning to everyone was that he was sad and expressed not liking himself. We checked in each week using a bucket metaphor, and he'd tell me how full his bucket was. Each week for that first year, he'd bend down and put his hand at his ankles and say, "I'm down here," or "I'm empty." Using expressive arts therapy weekly over the school year, we explored who he was and what was really going on for him. Before school let out for the summer, he came to the realization that he felt misunderstood, pegged as a bad kid and incapable of making good choices. He shared that when he lashed out at others, what he was really trying to say was, "I don't feel loved," or "I don't feel cared about or seen." He shared that he rejected others before they could reject him. I worked collaboratively with the school social worker, as well as the principal and behavior specialist at that school, sharing bits and pieces of what he told me would be okay to share about what he needed, and we worked to figure out a better path forward. Over the summertime, he and his family attended regular family therapy with me and worked so hard to support and love their child the way he was able to communicate that he needed to be loved and supported. And when school started this fall, I continued to mediate conversations between his parents and his school, working to repair and build those relationships up, as the school also cares so deeply about this child. Now, having just started his second semester of third grade, he has gone at least 2 months without any behavior slips. He has a wonderful teacher who he feels understood by, speaks happily about the staff at his school. He's outdoor for recess, playing with his peers, and has shown great progress in using coping skills and healthy communication when a conflict does arise, which still does occasionally. He's back to eating in the cafeteria, has changes to his IEP to reflect his mental health needs at the school, and most important of all, he is so much happier. For the past 2 months or so, when we check in about his bucket, he puts his hand on his head with a big smile and says, "I'm up here." Thank you for your time and hopefully your support of this bill.
Good afternoon, Senator Rafferty, Representative Brennan, and honorable members of the Education and Cultural Affairs Committee. My name is John McAniff, and I'm a resident of Cape Elizabeth. I've been the Chief Financial Officer at Sweetser since 2022. Prior to that, I was the Chief Financial Officer at Spurwink Services for 15 years. I'm here today to speak in favor of LD 2002, an act to provide incentives to schools that contract for certain social work and family therapy services. LD 2002 will enable community agencies to continue to provide much-needed mental health prevention services to children and families on school campuses and in their homes. The service is not currently working financially. It neither works for the community agencies, nor does it work for the clinicians. And for rural school districts, affordability of providing these critical services can be a barrier. Sweetser's Board of Directors and senior leadership is committed to providing this service, which is proven to reduce barriers for children to receive treatment in the public school setting. In fiscal year 2024, Sweetser's board approved a deficit in this program of $342,000. Sweetser's school-based program lost $560,000 in 2022, $376,000 in 2023, and has lost $438,000 through the first 5 months of fiscal year 2024. These negative margins are unsustainable. The underlying reasons for this center around a mismatch between the productivity expectations built into the rates and the amount of unbillable time that is part of the service. The main care rate works in an outpatient setting where the therapist can schedule back-to-back appointments. The school-based setting is different. The community-based clinicians co-located in the school are part of the school community and act as members of the student's team. As testimony mentioned earlier, there is a long list of non-billable activities that ultimately are required if a clinician is to truly make the biggest impact in their role. Common sense activities like meeting with educators on how to remove barriers to the student's learning and dealing with mental health or emotional crises that can ultimately arise. This is an important feature of the service. The clinician's participation in these ancillary activities is why the integrative service works clinically. The clinicians are paid fee for service. This means that they only receive compensation when they provide a billable service. The typical clinician makes $47.50 an hour when they provide a billable service. The typical fee-for-service clinician is able to bill for 800 hours of service, which equates to $38,000 per year for a master's level professional. This bill not only puts us on a path towards sustainability by reducing the deficits being absorbed by the community agencies, it allows providers like us to recruit and retain highly qualified clinicians, pay clinicians a livable salaried wage, help school districts provide mental health services, and ultimately avoid program closure. It's a win for students, families, schools, and our whole state. Thank you for your time, and I'm happy to answer any questions.